Wonderful. So welcome, good afternoon, and welcome to the webinar Implementing National Diabetes Prevention Program in Real World Setting, how we did it. Let me just try to share my screen again. And I apologize for the, here we go. Wonderful. So this webinar has been developed by the American Diabetes Association Public Health and Epidemiology Interest Group. The Public Health and Epidemiology Interest Group comprised of over 1,500 members and aims to increase public awareness of the epidemiology of diabetes and its complications and focus efforts on health promotion and community health strategies. This webinar today is also supported by the American Diabetes Association National Health Disparities Committee. The National Health Disparities Committee comprised of leading health equity and community health experts and serves as an advisory to the ADA work around reducing inequities facing populations affected by diabetes. So let me introduce myself. My name is Elisabetta Fatorno. I'm a physician, pharmacoepidemiologist, and associate professor of medicine at Brigham Women's Hospital in Boston and Harvard Medical School. And I'm currently the chair of the Public Health and Epidemiology Interest Group. So I will be the moderator, one of the moderators for today's webinars. Very looking forward to it as well. But before I start, I would like also to invite to welcome the attendees and introduce herself, Dr. Jessica Ye, who was really the core organizer of the webinar today. So Jessica, please feel free to introduce yourself.
Thank you so much, Elisabetta. Good afternoon, everyone. So I'm Jessica Ye. I am an associate professor and epidemiologist at Johns Hopkins University. My research focus on clinical trial and cohort study of diabetes, obesity, and cancer outcomes. I am the immediate past chair of the ADA's Public Health and Epidemiology Interest Group and a member of the ADA's National Health Disparity Committee. It's a pleasure to co-host today's webinar, and thank you for joining us.
Thanks so much, Jessica. So before I introduce the first speaker, I wanted to remind a couple of aspects to the audience today. So you will see you have a Q&A function at the bottom of your screen, very close to, I would say, the video function of the Zoom. So if you have any questions for the presenters today, please feel free to click on that icon. You will see Q&A written on it and type in your question. The plan so far is to collect all the questions and address all the questions at the end of the 6 presentations today. If you have general comments like technical problems or anything you would like to point out, you have also a chat function very close to the Q&A, as you will see, and probably many of you is very used to Zoom at this point. But please feel free also to use the chat function for general comments. So, and with this, it is now my pleasure to introduce our first presenter today, so Dr. Enrique Caballero. So Dr. Caballero is an endocrinologist and clinical investigator. He's the director of the Latino Diabetes Health in the Endocrinology Division at the Brigham Women's Hospital in Boston, as well as faculty director of International Innovation Programs and associate professor of medicine at Harvard Medical School. Dr. Caballero is the chair of the Healthcare Disparities Committee at the ADA. He has also been a co-investigator in the Diabetes Prevention Program and the Diabetes Prevention Program outcome study since its inception. So today, Dr. Caballero, as you can see from his first slide, will present on the prevention of type 2 diabetes, lessons from the Diabetes Prevention Program. And so welcome, Dr. Caballero. It's my pleasure to turn it over to you today.
Thank you, Elisabetta. Thank you, Jessica, for the webinar, inviting me to participate in it. I'm very excited about it. Obviously, this is a very important area for everybody really in the field of diabetes, because I think that preventing diabetes or delaying diabetes at least is possible. So I think it's important for everybody to be aware of that. Now, we're going to hear today a lot about the implementation of diabetes prevention programs, which I think is the core of this, but we thought that it would be important for everybody just to refresh their memory about what the diabetes prevention program and the diabetes prevention program outcome study is all about, since this is the foundation for the different programs that have been implemented nationally and internationally. Let me just start, and I will do my best to finish in the very few minutes that I have, because there's a lot to cover in this webinar. But remind everybody that we better understand now the pathophysiology of type 2 diabetes. And we know that people don't develop diabetes overnight. It's a process that takes usually many years, and it is possible to identify many of these abnormalities early on to properly intervene. Now, the DPP was developed as a study almost 30 years ago. So at that point in time, it was really more about insulin resistance, obesity, and beta cell dysfunction. Now, there's a lot of other players that have been added to the pathophysiology. And the reason why I'm saying this is because in the future, maybe other strategies may prove to be effective also, mostly from the pharmacological perspective in reducing weight, for example, and preventing diabetes, although that information is not available yet. The other point to remember is that in the diabetes prevention program, we included people with impaired glucose tolerance, which is one of the categories that determines pre-diabetes. The other one is impaired fasting glucose, and you'll see here the different criteria. And as a reminder, if people have both impaired fasting glucose and impaired glucose tolerance, as it happened in many of our participants in the DPP, the risk of type 2 diabetes is particularly high. So we targeted a very high risk population from that perspective. So the DPP is the largest diabetes prevention program really in the world, and one of the longest, along with the Daqing study in China. And as I said, it was started many years ago, specifically in 1996. So it's been now 26 years almost since the DPP was started. It was implemented in 20 different centers across the United States. And this is a program study sponsored by the NIH and NIDDK and many other agencies and corporations. Now, as we're going to talk today about the different programs, it's important to remember the population that we studied. We had a large population, more than 3,000 individuals. Look at the age, 50 as average, fasting plasma glucose of 106 milligrams per deciliter, BMI of 34. So the average is actually at that level, something that may not be the same in other prevention studies across the world, with very good blood pressure levels. Notably, a lot of them with family history of diabetes, which, as you well know, is one of the risk factors for type 2 diabetes. 16% of the women had history of gestational diabetes. A third of them with high cholesterol, 1 in 4 with hypertension, a good number of people that smoked in the past or were current smokers, and very few with history of cardiovascular disease. This is important because we actually excluded people with severe conditions like cardiovascular disease, renal disease, and others. And that may actually impact some of the things that you will hear from Dr. Jessica Ye in a couple of minutes. Now, we had initially 4 arms of the study. One was with troglitazone that was actually not continued for liver toxicity issues. So most of the results that we have in the DPP are with 3 arms of the study. And that was the intensive lifestyle modification arm, metformin, and the placebo arm of the study, more than 1,000 individuals in each of these groups. Now, important to remember, because this is the implication for what you're going to hear later in terms of the implementation of the programs, is that the main goal in the intensive lifestyle modification arm was for people to achieve and maintain at least a 7% weight loss, which, as I will show you, was actually achieved. The reduction in fat and caloric intake was the main focus. Again, this was a recommendation at that time, and physical activity at least 150 minutes per week. And this was conducted with a very intensive phase. In the first 24 weeks, people had to attend 16 sessions. And then during that time, they had to really get individual counseling very frequently on a weekly basis. So we were really supporting and providing a lot of the information to participants during that initial phase. Later on, the contact frequency was decreased, Initially, it was then once per month and then every 2 months and so forth during the study. So there was this initial phase, and that's honestly when the best results were seen, as you probably know already. Now, the metformin group received 850 milligrams twice a day. Now, this is obviously the figure that probably all of you have in your mind. The intensive lifestyle modification group was able to achieve that weight loss that I said, and the reduction in the development of type 2 diabetes was 58%. So a significant reduction, 31% for metformin. So the absolute winner here was intensive lifestyle modification, as I said earlier, and metformin did also a very good job. Something important is that all these results are applicable to both men and women. You can see here the highest conversion rates in the placebo group, intermediate for metformin, and lowest for those in the lifestyle modification groups. Now, obviously, as chair of the Healthcare Disparities Committee at the ADA, I have to say that obviously these interventions were equally effective in all racial ethnic groups that participated in the DPP, which I think is fantastic because this demonstrates that these interventions could be tailored to all different cultures and groups, which I think is very important. Now, something important before I finish is that when we look at the age subgroups, you can see here that metformin did not actually work very well in people above the age of 60, so very close conversion rates to those in the placebo arm. However, in younger individuals was very effective as lifestyle modification. And that's been one of the recommendations, that if we're thinking about who to give metformin to, it's probably the younger individuals that may benefit the most. Similarly, when we look at BMI subgroups, you can see that it is those with the highest BMI that responded best to metformin, very similar to lifestyle modification, and not very effective in those with a BMI under 30. So it's the younger individual with the higher BMI that responds better to metformin. Two groups I'm not showing them in the slide, that responded very well to metformin are women with history of gestational diabetes, very important for public health aspects, and also those that were very close to the higher levels of fasting plasma glucose. So this is my last slide. So the main message from the DPP at that time was that weight loss was obviously the main predictor of diabetes prevention. You can see there, very important, modest weight loss was very effective, a 16% reduction in risk for every 1 kilogram. So it's not a lot of weight loss that is needed in order to see some benefits. And physical activity by itself was not enough, but it's certainly a factor that helps people lose weight, but also to sustain that weight loss. All right, I think I'm going to stop here. I'm going to turn it over to Dr. Jessica J. to continue with now some of the most recent data in the DPP-OS, which is the continuation of the DPP. Thank you.
Thank you, Dr. Caballero. That's a wonderful overview and review of the DPP. And you point out the subgroup difference by age and and BMI. That's very important. Thank you for doing that. And so, so now I'm going to briefly review the main findings from the DPP outcome study and the policies of promoting national DPP. After DPP ended, all participants were provided a modified version of the DPP's lifestyle change programs. And the goal of the DPP-OS is to follow DPP participants to see if those in the lifestyle group or in the metformin group continue having a delay in the development of type 2 diabetes over time. And if they experience fewer health problems, such as cancer, cardiovascular disease, kidney disease, eye disease, and other age-related health problems. So this slide shows a weight change, A1C change, and the medication use over 10 years. And lifestyle group is indicated in like a purple lavender-ish type of color, and metformin is a red color, and placebo is this blue greenish colors. And as you can see here, during the 10 years of follow-up, the original lifestyle intervention group lost and then regained part of the weight. And the modest weight loss in the metformin group actually remained stable in the later years. And there was no significant change in weight in the placebo group. And in terms of A1C, the HbA1c was always lower in the metformin or the lifestyle intervention group compared to the placebo group. And in terms of medication use, more people in the placebo group using anti-diabetic drug over time than those in the metformin and lifestyle intervention group. So this slide shows the cumulative diabetes incidence over time, and the diabetes incidence rate are lower in the metformin and lifestyle intervention group than the placebo group. And compared to the placebo, diabetes incidence in 10 years reduced by 34% in lifestyle group and 18% in the metformin group. Most importantly, the median delay to diabetes onset was 4 years by lifestyle and 2 years by metformin compared to placebo. After 15 years, diabetes incidence rate was still lowest in the lifestyle intervention group. At year 15, diabetes incidence was 62% in placebo, 56% in metformin, and 55% in lifestyle. And in the relative scale, the incidence was lower by 27% in lifestyle intervention and by 18% in metformin treatment. This table shows a result in microvascular disease. After 15 years, the microvascular complications were not significantly reduced in the total cohort overall with either intervention. So the relative risk was 0.91 when lifestyle compared to placebo and was 1.05 when metformin compared to placebo. Neither were statistically significant. However, there were significant reduction in women and in Hispanic ethnic patients in the lifestyle intervention group. DPPOS published the mortality result last year in diabetes care, and over the median of 21 years, 453 participants died, and cancer was the leading cause of death, followed by cardiovascular disease. Neither metformin nor lifestyle modification reduced all-cause cancer or cardiovascular mortality rate. However, the important message was although mortality rate were not statistically significant after 21 years, we cannot ignore the benefit from lifestyle intervention and metformin on delaying diabetes onset and other microvascular diseases. Because of the success of the DPP intervention, particularly around lifestyle changes. So in 2010, the Congress authorized the CDC to establish the National Diabetes Prevention Program, NDPPs. And in 2016, Medicaid coverage for the National DPP Demonstration Project was conducted in Maryland and Oregon. And the purpose of the demonstration was to show how state Medicaid agency and state health department can collaborate to implement, deliver, and sustain coverage of national DPP. In 2018, the Medicare started to cover participation in the CDC's National Diabetes Prevention Program for those who are eligible. And starting in 2019, National DPP became a Medicaid covered benefit, which is an ideal approach to sustain the program financially. So currently, there are more than 2,000 CDC recognized organizations in the US, and all the programs use the CDC approved curriculums. And our next presenter will provide the latest update on the curriculum. Thank you.
Thanks so much, Dr. Ye. This was fantastic, and Dr. Caballero too. So it is my pleasure to introduce our next speaker now, Ms. Betsy Rodriguez. So Ms. Rodriguez is a senior public advisor at the Centers for Disease Control and Prevention in the Division of Diabetes Translation. She has more than 25 years of professional experience. She's a nurse, certified diabetes educator, author, bicultural specialist in health communication strategies, and the development of diabetes educational resources for Hispanics, Latinos, and other ethnic minorities group. Ms. Rodriguez is the author of the CDC National Diabetes Prevention Program Spanish Preventive Curriculum. And today, as again, you can see from the title of her slides, she will speak about the CDC Preventive Curriculum 2022 updates. So welcome, Ms. Rodriguez, and please go ahead.
Thank you for the invitation to share with you all the work that has been keeping me busy for the last year or so. So it is my pleasure to say we're done in English and in Spanish. This is the second time that has been going through the process. I was the author of the previous one, so now I have the pleasure to present to you the work that have been taking a whole year of my life and giving me more white hair to have to the best possible way the most current science behind the curricula that it's part of the National Diabetes Prevention Program, the CDC Preventive Curriculum. So we're gonna be talking today about what has changed and what that means to you. Excuse me, I'm having issues here to find my arrows. Okay, here it is. So today, in these few minutes that I have with you, I'm gonna be talking about the curricular updates, what is the rationale and the methodology we use. We're gonna be talking briefly about the field testing. We're gonna be sharing with you a summary of the final changes and then what this means to you. And then at the end, we're gonna be having a Q&A section that I'm more than happy to answer to my best ability. So some background here for you, FYI. So in 2016, CDC launched the Preventive Curriculum, which builds on lessons learned from the original Diabetes Prevention Program study and follow-up effectiveness studies. Since the release of the 2016 curriculum, the evidence base has grown for the understanding of relationship between diet and cardiometabolic risk, as well as evolution on how we think about food and nutrients, including a greater emphasis on whole foods and dietary patterns. Since 2016, CDC has also worked to identify key competencies and skills for lifestyle change program lifestyle coaches that contribute to participant success in the program. CDC continuously work to ensure that lifestyle change programs have access to the most accurate content aligned with the best practices. The aims of these updates were to align the preventive curriculum with the current science on type 2 diabetes prevention, as well as with the best practices on health and wellness coaches. We also work to ensure that the curriculum reflects feedback and lessons learned from lifestyle coaches. In terms of the methods, let me explain with you very briefly the process that we went through. The Division of Diabetes Translation at CDC compiled a summary of evidence from the United States Department of Health Dietary Guidelines for Americans 2020-2025 and the American Diabetes Association Standard of Care, clinical practice guidelines on the management and prevention of obesity from the US, from Canada, and from Europe, as well as published studies on clinical nutrition practices for weight loss. Convene a panel of experts in nutrition, in weight loss, in type 2 diabetes prevention, and type 2 diabetes prevention programs to review the evidence and identify content updates for Preventive 2. We also review strategies for engaging participants in lifestyle coaches and conducted observations of programs and interviews with lifestyle coaches, with participants and program administrators to identify engagement challenges and strategies. So here is the summary of the panel recommendations. Those were around nutritional needs that should be met primarily from whole foods with focus on nutrients and recommended amounts, limiting the calories from added sugars and saturated fats and reduce sodium intake, eat a high quality diet for the long-term weight maintenance. Calorie reduction remains as an important consideration in short-term weight loss. Diets higher in foods that contain healthy fats are associated with weight loss than low-fat diets. And then increased intakes of whole food high in dietary fiber is associated with weight reduction. And lastly, to address other lifestyle factors, including physical inactivity, alcohol use, smoking, and sleep. So in terms of the participant engagement, what we learned from lifestyle coaches is that the engagement challenges change over the course of the program. So engagement strategies should be specific to the challenges groups are having based on where they are in the program. Lifestyle coaches also emphasize that engaging sections include attention to the dynamics of the group, so the coach can meet participants where they are, the use of active coaching strategies, as well as having more open-ended questions, reflective listening, and one-on-one attention, which is the essence of a good coach. So the 2021 updates to the curriculum include focus on eating well and strategies for weight loss to emphasize whole foods and physical activity while shifting away from a focus on a specific macronutrients. There is also greater flexibility in allowing participants to tailor approaches to healthy eating and weight loss. There is a variety of approaches to healthy eating and weight loss, and the curriculum adds that flexibility to participants to select approaches that will work for them. Then there is also great emphasis on habit formation and setting personal, meaningful individual goals. And finally, there is a lot we have been done around enhancing cultural relevance for the English and for the Spanish curricula through food activity choices and storytelling. We also add tips for lifestyle coaches that can consider to address diverse beliefs, traditional celebrations, and holidays with various ethnic groups to discuss how those can impact participant activities around eating habits at home. For the Spanish curricula, this meant encouraging consideration for differences across Spanish cultures. There is also a lot of increased use of acting coaching strategies that include games, storytelling, open-ended questions, along with additional resources for participants that allow the coach to spend more time in coaching as opposed to covering the curricula. There is a lot of guidance for engaging participants between sections, and there is a lot of guidance for adapting the curriculum to support virtual delivery. And finally, we have incorporated the 2021 Diabetes Prevention Program Recognition Standards. We also, in terms of the look and feel, we increase the use of graphic in the materials, which will increase relevancy for participants and apply adult learning principles. We updated the content and the images to enhance cultural representations of people and food. We revised the layout to content to provide greater clarity and appeal. And we integrated personal success tool as a retention tool and habit formation techniques to complement sections, topics, including steps they can take to develop their habits. And in here, you just see the quantity of changes. I'm not going to get into all the details, but just to summarize that we revised the curricula to focus on whole food physical activity while shifting away from micronutrients. We integrated more participant-centered activities with more opportunities for engagement and building self-efficacy. And then also adapted the curricula for in-person delivery or distant learning. In terms of the Preventive curriculum, which is my proud, I have to admit that, it has always very important that the Spanish Preventive curriculum was culturally adapted and not just a literal translation. With the 2021 update, CDC have further enhanced the cultural relevancy of the Spanish version. While efforts were made with both the English and the Spanish Preventive curriculum to reflect the diverse audience of program participants and how the degree to which the content was revised or added, it's different between the two versions. It's very different. Updates and revision of the Spanish curriculum include personal profiles. We were developing and integrated into the Preventive curriculum for the coach to understand the uniqueness of the participant in their groups and to serve as the lens through they can view various options for activities and discussions topics. It provides an insight into what each coach group activity might enjoy or find useful. In terms of cultural appropriate imaginary, when possible, images that reflect Hispano-Latino individuals, families, and community settings, as well as the traditional meals and foods. We have made a lot of changes here with more relatable content. For example, we switched from pudín de chocolate to dulce de leche or churro. And then there is an appropriate Spanish language. We revised the language to replace phrases or terms, getting away from the scientific, technical, or health-centric language. And then in terms of culturally adapted activities and strategies, we added tips and examples for lifestyle coaches to emphasize to participants that they don't need to stop eating the traditional meals or foods. So there is a lot about stories and using the stories with the participant to make the content more relatable and join in a way the participant in the stage they are in their journey to losing that weight that is expected. In terms of the field testing, the updaters were field tested with active cohorts, with lifestyle coaches, with master trainers, and with participants. And all seems to be very seamless for lifestyle coaches and participants. All of them were very receptive to the materials. There were very minor recommendations that were done. So we were very happy with the result of the field testing. So to end, I would like to give you a summary of the final changes. So as you can see here, CDC has worked to Preventive curriculum in line with the experienced lifestyle coaches and what they are doing in the field to make it easier for new coaches to get started and feeling more comfortable sooner. And on these slides, as you can see, it's full of what has changed for the Preventive curriculum. Virtual delivery, we put a lot of emphasis on that. This is one of the legacies from the pandemic, right? So the Preventive curricula is now adapted to accommodate facilitating online on through distant learning. Modifications to all part of the curriculum include activities and discussions, make it easier for lifestyle coach to transition to virtual learning when needed. In terms of nutrition and weight loss themes, the Preventive curriculum now supports participants in creating new routines that can become new healthy habits that last a lifetime. And we also included another resource from CDC that is called Personal Success Tool modules. And this is a interactive web-based modules that now the lifestyle coach and participant guides contain references, links to those resources that are there that help to reinforce the program content in a timely manner. So with this, I end my update. And what does it mean to you? It means that now you have a resource that is taking into consideration the experience of lifestyle coaches, the trainers, and the participants in this program. It has been field tested to make it more relatable to the experiences that the programs are facing right now. So we're hoping that this new curriculum will give especially lifestyle coaches a new way to conduct the program, spending time in what they're supposed to be doing, which is coaching the people in the journey to prevent type 2 diabetes. So thank you.
Thanks so much for the wonderful presentation. So please, if you have questions, as mentioned before, type in your question in the Q&A box at this point. We're going to discuss all questions to presenters. Just want to remind at the end of the 6th presentation. But please feel free to include the questions at this point if you have some. Okay, wonderful. So it is now my pleasure to introduce our next speaker, Dr. Nisa Marator. Dr. Marator is an associate professor of medicine at Johns Hopkins and is a board-certified general internist with an active primary care practice. She is also director of community program implementation for the Johns Hopkins Bronchitis Center. And in this role, she leads the implementation of the diabetes prevention program across Johns Hopkins. Dr. Marator will discuss a diabetes prevention program model in Baltimore communities. So Dr. Marator, the floor is yours. Thanks so much.
Okay, are you seeing my slides properly? Okay, great. So I'm really excited to be here. I really appreciate being invited with this esteemed group. Hearing Ms. Rodriguez talk about the new curriculum, our team's really excited. A lot of them are on the call today, and we're really great. It was great to hear your insights. Lots of questions coming, I think. So we are getting to implement the CDC's curricula in our community, and I'm going to talk a little bit about our Baltimore City experience. And I'm presenting on behalf of a very large team that I'll mention later in the talk. All right, here we go. So I was going to give you a little background on our context in Baltimore City, talk about our center and kind of what our model's been, and then talk about a recent expansion that we have that is huge and really exciting for us. And I feel very fortunate to be in Maryland right now, where there's a lot of emphasis being placed on diabetes prevention. So I wanted to start, I won't go through all of these numbers, but I wanted to give you a sense. One thing is that we don't collect great data on diabetes in Baltimore City, and it's like that in a lot of cities. So I can't give you a lot of zip code specific detailed data. We have like the BRFSS stuff, about self-reported rates of diabetes, et cetera, but not a lot of epidemiology, being focused on. So what I have here are just some markers for you to understand kind of who we work with. Baltimore City overall, is shown here in this first column. And then there are two neighborhoods right around Johns Hopkins Hospital that we work really closely with and reflect a lot of the participants that I'll be showing you results from. And you can see that, the majority of them report Black race. We have, the median household income in our population is about half of that, of Baltimore City, which isn't all that high to begin with. Lots of issues that you could see is contributing to social determinants of health. I included rat service requests, homicides, youth homicides, food desert. It's all pretty bad where we are. And I won't go over the details anymore, but I wanted to give you an idea in our context. So the Johns Hopkins Bronchitis Center, I know that some of you knew Fred Bronchitti because he was part of the DPP prior to his passing. We have a center in his name, the Johns Hopkins Bronchitis Center for the Advancement of Community Care. And our mission is to take evidence-based programs like the DPP and really bring it to our community in partnership with them. And I'll talk a little bit about how we've gotten to do that. But that's our focus. And I have to say that I was a medical student when the DPP was stopped early, and the day that that press release came out, I decided I was going to work on the DPP, and it's been like 20 years now, and I'm really excited to be here and be doing the implementation part. So this is our general model in the Bronchitis Center. So we're, Johns Hopkins University, the academic part of this partnership. We have a lot of expertise. I'll show you some of our folks, but we, one of our main senior interventionist was originally part of the DPP and an interventionist for the trial. Several co-investigators from the DPP, including myself, that are part of this team. And we really focus on the intervention, providing a lead coach, implementing the program according to evidence with our experience and also with guidance from the CDC. We take care of all the data analyses, reporting, billing and compliance now that that's come online. And we also have been fortunate to always have resources for wraparound services and provide the materials. And then our community partners, which are primarily churches in the community that we serve, they all provide a champion or more than one. We work closely together in weekly to bi-weekly meetings as we implement the program. Oftentimes they'll have a person that wants to volunteer as a coach. We train them to be part of our groups. And the community partner really works with us to engage the community, because that's not our expertise. Our expertise is just knowing what the DPP intervention should look like. And then we provide, prior to the pandemic, all of our programs were offsite at community-based organizations, mainly churches. And then logistics, is something going to be closed? Is this not a good time of year? Like, we shouldn't start a group the weekend before Easter, for example. Like, those are the kinds of things that we work with our community partners on. And then together we talk about like getting people in, keeping them in, and have lots of meetings, and really do see this as a partnership. And we think that's the reason we've been successful. This just gives you an idea of the partners. These are our current partners, where even during the pandemic, we started recently, I'll use Gardner Prairie Christian Church here. We had done an in-person group that had to go to virtual during the pandemic, and we just started our first all virtual group, but still based with their church. So still lots of support from them. And that's really been the model that we've been using across the results that I'll show you. So this is our team. I wanted to show this because I think that we would have a lot more difficulty with success if we didn't have the infrastructure that we have. And it's taken time to build to this point. But I think for programs to be successful, you really do need to have an infrastructure if you want to be able to scale. So there are two physicians that are kind of part of our Bronchitis Center community program implementation team. I'm one of them. And then we have a program director, Megan Brown, who's really great at kind of the administrative day-to-day and making sure that I don't overspend the money. But we also have really good interventionists. So we've really been, I'm fortunate that we have Kathy Maholsky be part of our team for a long time, and she's been with us from the start. We've been fortunate to recruit another dietitian, Sophie Lover, and then also we have a pretty good data team. And I won't get into all the details, but you can see that there are a lot of people who make this work. We coordinate with all these community partners. We have community health worker support, and then we have a lot of coaches. A lot of them are have joined our team recently. We have an online program that I won't discuss today. So, what our approach has really been, and this I think is pretty simplified, is we work with our community partners to figure out their context. If they tell us that certain content isn't going to be important, say something's not there. I'll give an example. We had a lot of issues come up with emotional eating, or what people were calling emotional eating, during our first couple of years of doing the program. And working with Kathy Maholsky and other folks on our team, we developed a session called Emotions in You and got that approved by the CDC for use in our curriculum. That's been very helpful. And those are the kinds of things that if we see with our communities that we're not addressing something, we go and do it and spend a lot of time on that. We have community health worker support. And if there are questions about how we do that, I can talk about that if there's time. But basically we do now a social determinants of health assessment for everyone who joins one of our groups. And then we follow up individually with people who might be having any challenges. We have a very robust infrastructure for training and oversight, and that's not just for master training, but also to train on how to collect data, how to keep the data, how to be private, and also oversight, so ongoing assessment during program implementation. During the pandemic, we weren't sure what was going to happen. If we had about 50 people in our groups when March 2020 came along, and in person, and we moved them all to remote. And I think 1 or 2 of them left the program after that, but we really were very pleased with how things went. Their weight loss was the same. And what we figured out we needed to do for the population we serve was put some extra time into orienting people to our remote platform. So we use Zoom. And we did a formal training. We do a formal training for our staff on how to use Zoom features for the DPP. And then we do one-on-one individualized training for participants. And we are fortunate to have the resources to have someone on our sessions to help with technical assistance to make sure that everyone can participate. Some of the wraparound services we've provided, like we've provided a web camera if someone needed that, so that they could actually be part of the groups. I won't go over the other details. I think Ms. Rodriguez knows a lot more about this and has already explained a lot of these things, but being interactive is really important. So let me go to the next slide here. So we're really proud of our outcomes. So we've managed to keep nearly 70% of people who join our program. That's been pretty consistent. This is from 2016. We've had 178 people who started our programs and could have finished 12 months. We probably already enrolled like another 150 this year. So we're really expanding. People attend 91%. Our session attendance is 91%. And our average weight loss has been 5.4%. And I have to say that we're very proud of that, partly because when we started, we were the only DPP in our area. And there was a lot of thought from different leaders that maybe that wouldn't be successful here in our community. And we were able to prove them wrong. So we named our program Power to Stop Diabetes in conjunction with our community partners. We started out with a very small group, all of whom finished. As Jessica Ye said, we did participate in the Medicaid demonstration that took place in Maryland and Oregon. Johns Hopkins, our institution, has invested now in the DPP. And the thing I was going to end with is that at the state level, we've had huge investment in the DPP now. We're somewhere in the 200 range in terms of how many people are finishing our programs, but by the time 2025 comes around, we'll probably be somewhere in the 3,000 range based on planned expansion. So we're pretty psyched. This is the last slide I have. And what this is really the expansion that we're going through right now, which is called the Baltimore Metropolitan Diabetes Regional Partnership. And this is why I said I feel lucky to be in Maryland. I won't get into Maryland's payment system, but it's different from all the other states, and a lot of people complain about it. But we're under this total cost of care model, where the state actually monitors our hospitals and say, you get this much money per year to spend on inpatient care, and you need to stay within that because that's all you're getting. And in return, they say that you need to be focusing then on initiatives to keep people out of the hospital, et cetera. And they help us with that. They awarded us, our institution and the University of Maryland, a $43 million grant in 2020 to basically focus on developing and implementing the diabetes prevention program, and then diabetes self-management training, which I won't discuss today. And for our DPP, it's very focused on these zip codes. So these are the zip codes that we've been in Baltimore City that we've been serving and will be expanding. And so that's really the expansion to like 2,000 or 3,000 people that we'll be doing. So exciting times for us. And we think that we have really been able to develop something special, and we would be really keen on sharing that with others, across the country. If there are like communities, we would not be able to do this without our DPP participants. They're awesome. We actually have more sessions than the 22 that are required because they want to meet with us more often. So we actually offer 33 sessions across the year. The community partners have been amazing. And of course, the Bronchitis Center DPP team, many of you are on today, thank you. And then of course, we've had a lot of funding from grants, and it's always about trying to find the next bit of funding. But thank you for your time. I stayed under 12 minutes, and I will stop sharing.
Wonderful. Thank you so much, Dr. Marator. So it's my pleasure to introduce our next presenter, Dr. Stephanie Fitzpatrick. Dr. Fitzpatrick is a senior investigator at the Kaiser Permanente Center for Health Research and the senior manager of multicultural program at WW, formerly Weight Watchers. As a clinical health psychologist and behavioral medicine researcher, her work focuses on implementing evidence-based behavioral interventions for obesity and chronic disease management in clinical and community-based settings. So today, Dr. Patrick will talk about implementing a diabetes prevention program for Medicare beneficiaries in an integrated health system. So I will now turn it over to Dr. Fitzpatrick. Thank you very much.
Thank you, Elisabetta, and thank you to Jessica, as well as the American Diabetes Association, for inviting me to present today. So my presentation is going to be a little bit different from the ones you've heard so far, that we're actually going to be talking about evaluating the implementation of DPP in our integrated healthcare system of Kaiser Permanente. And things just kind of linked up at the right time. As they were doing an implementation pilot, we were able to get some funding to do kind of a natural experiment study. So I first want to make sure I acknowledge our funders, the National Institute of Diabetes and Digestive and Kidney Diseases, NIDDK, as well as some of our collaborators within Kaiser Permanente Northwest, Amada Health, which I'll get into their relationship in a few minutes. My co-investigators, particularly Dr. Stephen Fortman, who was co-PI on this work with me, as well as our research team. So let me just first kind of describe the setting here. So Kaiser Permanente Northwest is one of 8 regions of Kaiser Permanente in the US. The Northwest region covers Oregon as well as Southwest Washington. We have about 600,000 plus members. Approximately a third of them have prediabetes, 40% are living with obesity, and about 12% are living with diabetes. And we have a pretty comprehensive electronic health record system that's based on Epic. So as Jessica had shared, in 2018, CMS decided to start to reimburse DPP for Medicare beneficiaries. And so ahead of that time, if you all remember, the proposed rule had came out around really 2016 or so and wanted people to kind of weigh in. And at that time, Kaiser Permanente Northwest started to think, well, maybe we should start to plan ahead. This is probably going to go through. How can we start to kind of pilot and see, how do we recruit? How do we enroll? How do we deliver DPP successfully to our members? And so in 2017, they decided to put together an implementation pilot. And at that time, Dr. Glauber and others had put together kind of a predictive model predicting diabetes risk over 2 years based on BMI and A1C. So Kaiser Permanente Northwest decided to use a population health approach to identify members that would be eligible for DPP based on BMI and A1C, particularly focusing on those at highest risk, so those with a BMI greater than or equal to 30, and particularly honing in on those with an A1C 6 to 6.4. But since Medicare also had kind of that larger span, that whole pre-diabetes span of A1C 5.7 to 6.4, they, for this initial pilot, went with a wider range for A1C. Also focusing just on those who are 65 to 75 years of age to catch that Medicare beneficiaries. And also the members could not have already been on the diabetes registry, meaning they were not already diagnosed with diabetes. And all of our members were identified using the electronic health record, again, using this population health approach. So at the time, in 2017 and on, there's kind of 3 options for diabetes prevention at Kaiser Permanente Northwest. There's a digital DPP option that's provided by Amada Health. Kaiser had already had a relationship with Amada Health prior to the pilot in 2017, but it was only offered to employees. So this would have been the first kind of time testing this with actual patients and members. And Amada Health, for those who are not familiar with this program, it is an online-based program. It is CDC recognized, CDC certified translation of the DPP lifestyle intervention. It's delivered in a small group format with a health coach. They have the 16 lessons that are based on the national DPP curriculum, as well as the maintenance phase lessons. Participants also receive electronic tracking tools, such as a Bluetooth wireless scale. Later on in 2017, Kaiser Permanente Northwest also developed kind of an in-house diabetes prevention program called Preventing Diabetes Program, PDP. It was based on the national DPP curriculum as well. It was in-person group meetings weekly for the first 6 months and then monthly for the next 6 months after. And then our standard usual care, there's a number of internal programs related to diabetes prevention that's offered to members related to both diabetes prevention and weight management offered by the Health Engagement and Wellness Services Department. And that includes health coaching, in-person groups, and live webinars. For the talk today, I'm just going to be presenting our results on the digital DPP, as well as some from the usual care. So once eligible members were identified using the electronic health record, they received a letter via the patient portal, the electronic patient portal, and later on in April 2017, the letter talked about certainly diabetes is preventable, and immediately went into options for them, particularly in terms of being able to enroll in the Amada Health program. They got their own unique login to be able to go to the website directly on their own and to sign up. And then Amada Health provided information back to Kaiser for us to be able to then track who actually was enrolled and how many sessions they attended. So just here, this diagram is just to give you an idea of the recruitment and enrollment in digital DPP. Approximately 4,132 Kaiser members were invited to participate. 587 clicked on that link in the letter that they received and submitted an application. A little over 3,500 did not apply for digital DPP. 549 were accepted, 511 enrolled. A little over 3,600 did not enroll. I should also say that there was a limited number of slots. Actually, there was a limit of 500 slots to enroll in digital DPP. The slots went within 48 hours, so that's how those extra 11 were able to get through, but certainly a high demand for this program. So then in terms of our evaluation, we wanted to know, okay, how do Kaiser members who enrolled in Amada Health or digital DPP compare to those not enrolled on their change in weight and A1C over 12 and 24 months? We also wanted to explore factors associated with program enrollment, satisfaction, and continued participation, so continuing on in that maintenance phase, using qualitative interviews and surveys, and we also conducted some cost and cost effectiveness analysis. I'm just going to present on results from number 1 today. In terms of our outcome measures, all of our clinical and healthcare utilization data came from the electronic health record, so truly pragmatic in nature. We didn't want to do too much actual data collection from members themselves, so to make this, based off the EHR as much as possible. So all available weights and A1C measurements that were taken from May 2017 to June 2019 were included in our statistical models. And so in terms of our evaluation analytic data set, as I said before, 511 members enrolled in digital DPP, 472 of those were included in our analyses. They were either removed because they either developed cancer at some point in time or had some missing covariate data. And among those who were not enrolled, we included a little over 3,400 in our analysis. In terms of our analysis, because we were not able to randomize participants to digital DPP or not, we had to use a number of different approaches in terms of adjusting for possible confounders. So one, we adjusted for a number of different covariates that you see here, demographic covariates, as well as some clinical measures at baseline, particularly baseline weight and A1C. And we also tracked whether or not members were prescribed metformin at any time over the 24 months that we were following them. So there was a time variant covariate. We also used our estimated propensity score for enrolling in digital DPP. And that propensity score included all the covariates that I have listed here, as well as kind of baseline healthcare utilization, diagnosis of chronic comorbidities or mental health conditions. And we counted baseline as 12 months prior to them receiving the letter to enroll in digital DPP in April 2017. We use a linear mixed effects piecewise modeling approach. We use this piecewise modeling approach because, as you saw with the outcome, the DPP outcome study, unfortunately, with any behavioral weight management intervention, we see that uptick after that first 6 or 7 months. So we wanted to make sure we captured if that was going to be happening in our data. And then because our members only received digital DPP for 12 months, we wanted to then see, well, what happened the following 12 months to be able to get their full 24 months of data. I apologize for the small print here in terms of table 1, but I'll just walk you through some of these numbers here. The not enrolled were about a year or so older than those who were enrolled. As what we typically see in behavioral interventions, more women enrolled than men. Also, those who were enrolled were less likely to be smokers, or they were actually never smokers. Those who were enrolled also so happened to live in neighborhoods with a high school or greater education, as well as a median neighborhood household income, a little over $66,000 compared to not enrolled, which is a little bit lower. And also our enrolled participants had a greater number of specialty care visits prior to enrolling in digital DPP. Here is just a bar graph showing you kind of enrollment and attendance over time. Pretty good in terms of session completion. About 3/4 of them completed all 16 lessons. Almost 90% of those who initially enrolled continued on with the maintenance program. In terms of our outcomes, you can see here the black solid line is our enrolled participants in digital DPP. The gray dashed line is those who are not enrolled. Pretty distinct in terms of there's a significant decline in weight. In those first 7 months, there's a little bit of an uptick in those who are enrolled in digital DPP. But again, as you look at either 7, 12, or 24 months, those who were enrolled had greater weight loss than those who did not enroll in digital DPP. To speak more in terms of the clinical side, in terms of percent change in weight, at 7 months, those who were enrolled lost about 4.7% of their initial weight. So not quite the 5%, but still in that clinically significant range of 3 to 5%. Also 4% weight loss at 12 months, and then 2.3% weight loss over the entire 24 months. Just want to point out that that 4% weight loss at 12 months is pretty similar to what we see in the national DPP in terms of 4% weight loss, and those are in-person groups. And then for A1C, it pops up here, back. A1C, we see a little bit of a minor decline in A1C for those who are enrolled in digital DPP. And those first 7 months, I believe, was like a 0.05%. So not clinically significant, but certainly statistically significant decline in difference from what we see in the not enrolled folks. We also looked at probability of developing diabetes over the 24 months, even though the odds ratio suggests that those who were enrolled in digital DPP were less likely to develop diabetes over the 24 months, that odds ratio was not statistically significant. So just to summarize, certainly a population health approach to identify, recruit, and enroll eligible patients was overall successful. As I mentioned before, we were able to enroll 500 participants within 48 hours. Also, patients enrolled in digital DPP had significantly greater weight loss than those not enrolled. I was not able to present the cost effectiveness, the cost analysis, but digital DPP was more cost effective than usual care, particularly among those at high risk for developing type 2 diabetes in the next 2 years. Just quickly, in terms of some lessons learned, even though the population health, the sending out letters via the patient portal was successful, there were still people who were missed. If you think about that, still means that they have to have access to email and internet to be able to get that letter in the first place. So perhaps there were some folks that we left out by using this approach, and so thinking about other methods. Important to kind of track and closely follow those who enroll and those who do not enroll, and also considering those who did not enroll initially to re-invite them later on, because people always change their mind and things change over time. To have a bigger impact, I think, certainly focusing more on those higher risks. So thinking about those with A1C of 6.3, 6.4, that's also where we saw more of the cost effectiveness. And then certainly having a weight loss maintenance plan beyond the digital DPP in place. So at Kaiser Permanente Northwest, we had our health coaches start to call and provide phone coaching to those who had participated to help them to maintain their results. I just have here a list of our publications that we have coming out soon and my contact information, and I'll stop there.
Thanks so much, Dr. Fitzpatrick. So we can now move. I'm very happy to introduce our final presenter, is Dr. Amy Nunez for today. Dr. Nunez has 30 years of professional experience. He's a physician, educator, and community health instructor at the Pond School of Medicine in Puerto Rico. He's certified as a master trainer of lifestyles by the University of Pittsburgh for the CDC Diabetes Prevention Program. And today, Dr. Nunez will talk about implementing diabetes prevention program in rural Puerto Rico. So thank you so much, Dr. Nunez, and the podium is yours.
Dr. Nunez, you're muted.
I'm sorry, right now. Thank you for having me. Okay. More than a technical aspect, I want to tell you a story of overcoming with the purpose of reducing type 2 diabetes. Rural environments offer challenge to reach the goal of implementing our program to the ends of the world. This is a Puerto Rico DPP, a resilient program. In Puerto Rico, we shake a fruit tree and many diabetics fall. Doesn't seem funny? But personally, I have 2 children who use insulin. Just hundreds of thousands of families and half children are affected by diabetes in Puerto Rico. We must cut a generational incidence in health, and yes, it's possible. 1.8 of every 100 Medicare beneficiaries consume preventive service. This means that the population does not use prevention service, and it's not clear about the concept of primary prevention. So in addition to being a challenge to present a change of culture in society, it is also implied and an effort at education for children. Utuado is in the central mountain range of northwestern Puerto Rico. We must emphasize that it is a health region with highest prevalence. The prevalence is 19.3, you see? Our location is in the municipality of Utuado with agreement with the mayor and bipartisan consensus with legislative assembly of municipality, which is a real success because it shows the need for prevention in the town. The Puerto Rico DPP is a connected health model to establish a diabetes prevention system that complies with the expansion of DPP and 4 pillars of the national diabetes prevention program. First, training and increasing worker. Second, quality assurance recognition program. Third, delivery and intervention on sites. And 4, a health marketing adoption support. According to the World Health Organization, Puerto Rico has the highest prevalence of diabetes in the America. It is also number 18 in the world. 18 in the world, surpassed by Pacific Islands and some Asian countries. Here with the first group. At the end of 2015, the mission is important to change people behavior so that they are closer to improving health by practicing permanent habits and lifestyle changes. We never imagined what this was going to happen in 2017 when Hurricane Maria hit us. Hurricane Maria did not stop our work. Despite losing power. Almost all the communication towers had collapsed, and we have to meet our schedule of sending data to CDC under a bridge 20 miles from, our city, where there was only internet in the region. This was a test of cybersecurity in business continuity in connected health, and we won. A full year passed until the restored to power, opening roads between mountains, and thank God we were able to graduate our first group in December 2017. Opening way something my children's insulin was damaged, and we had to make our way to distant town through the mountains. Thousands of diabetics were deprived of insulin, reflecting to heal needs at these rural areas. We need to prevent diabetes prevention mellitus type 2. Sorry. Sometimes there are barriers to overcome. The application of change behavior manages itself in this lady. She completed class through telehealth, and the doctor took her of medication Lopitol that she had been taking for 10 years, control her glucose, and she lost 10 pounds. Great. One of the internship activities is going to a restaurant whose dishes are high in calories. We went to Chili's restaurant. This is a commercial. In an average dish, aiming all of 561 calories. Is that great? An activity to teach of evaluate content calories and fat in a food why in supplements. This is an activity to practice. Appropriate screening and exercise safety of clinical data. The American College for Medicine clinical management model is ideal for a program in which physical activity is used. We include it within quality assurance, and it is essential for preventive primary care and healthcare. You see the icon of the program. The name is Plácido Dulzón, similar like Plastic Sweet. Our program model called 7 Step to Wellness present a statistical constant that exceeds 60% retention in the 60 session, and it is due to this program. A priority of program is to train physician and health professional to lifestyle awareness so they can measure patient health improvement through fitness in the field. You see, Dr. Soto? The motivational program, Sube la Cima, is the climb top to inspire each participant to reach their highest levels of wellness. Our motivational program, we also put to the test during the hurricane and keep participants inspired to finish. This is how we are able to complete it. We give each one a medal for achievements in health obtained. This is the day of the medal. Here the ladies and doctors of the program. Kids Run to Prevention. This is a program, is part of the empowering new generation of health professionals in high school to health promoters. And this is our internship in health promoters and the medical fitness laboratory. This is a special project for us. We want to make a digital diabetes prevention program coaching school. We conduct a campaign right now. The name is My Superpower Innate Immunity Against COVID-19. We recently started our impact campaign in the municipality of surrounding towns, recruiting community leaders to systematically prevent and with scientific evidence reduce the incidence of each neighborhood of town of Utuado or Utuado. It remains for us to express that fulfill the first phase. Our mission is equipped to open 10 centers to provide service to more than 30,000 people in 10 towns throughout the island. So help us, God. I engage the people to prevent diabetes type 2 in rural areas. It's a high honor of gratification, but necessary to improve the population health in my country. I encourage you to impact the health of others. Thank you.
Thank you very much, Dr. Nunez. Wonderful. So I want to thank all the speakers for the great talks and discussions so far. And I think we can officially open our Q&A session. So I see we have a few questions in the chat and the Q&A. Before I will move to the first question, I wanted to invite also Dr. Caballero to join me in moderating this session today. And I think we can maybe start by the first. Very happy to read through the first question that we have received. I think the question might addressing Betsy more specifically, but let me read it. Sophie Louver is wondering, she's curious why eating more plants was not included as a panel recommendation when reviewing the latest nutrition literature. Was it a strategic decision to recommend all food intake without referencing plants? Any?
I'm sorry, can you repeat the question for me again, please?
So the question is why eating more plants was not included as a panel recommendation when reviewing the latest nutrition literature.
There is some of it included in there. We try to stick to the American Dietetic Association advice, as well as the American Nutritional Guidelines. But the emphasis was mostly on getting away from the old statement of macronutrients, as opposed to getting to the details of that. But there are some nuances of that is included. I didn't say it because I was just giving kind of the overall kind of emphasis that we're doing here. So the main emphasis is focusing on patterns, that there is no particular diet for a particular person. So there's based on patterns, lifestyle, cultures, and all of those things. And then the emphasis has been through all the new updates on habit forming, because we know that once habit formings are incorporated, behaviors will start happening. So that's basically the emphasis. So to long answer for a short question is, yes, it was considered, but the emphasis is mostly on macronutrients, getting away from macronutrients.
Wonderful, thank you.
Elisabetta, may I ask a couple of questions that I see here? Well, first, let me just clarify one thing, because there was a comment there in the past, and I probably sort of misspoke in the last slide that I presented. Physical activity is important. And in fact, physical activity was inversely related to incident diabetes in the DPP cohort. So physical activity is, of course, very important, as well as what we said about weight loss. All right, so I see two questions, and I welcome actually two people that have been instrumental to the DPP here, Linda Delahanty and Sharon Edelstein, who I say hello to. And they have two questions for you, Stephanie. One is from Sharon about whether you observe significant reduction in diabetes risk for those with higher A1C levels. Do you want to answer that? And I'll ask you the second.
Sure. So that's a really good question. We actually had a very, very small number of participants actually convert over to diabetes. So we did not look at it from that breakdown of if you're 6.3 to 6.4, starting out were you less likely, but that is something we can certainly go back and do. We just didn't have a good enough sample size to do a deep dive into that as of right now.
Okay, great, thank you. And the other question is from Linda Delahanty about the cost effectiveness information. I think you had a slide. I'm not sure if you were able to fully show it, but I don't know if you don't mind if you have it handy, maybe to show that very quickly, or comment on the cost effectiveness analysis of your study. Obviously, for all of us in the DPP, DPPOS, that has been one of the important concerns. I mean, the DPP clearly demonstrated that it's a cost-effective, the interventions are cost-effective, but what about what's happening in the real world? Can you comment on that, please, Stephanie?
Yeah, and I apologize. That was not meant to be a teaser. That was me having glitches with my Zoom that you even saw that slide.
Okay.
And I should also say that that manuscript is under review in terms of our cost analysis and cost effectiveness. What I will say is that when we looked at total cost, certainly at baseline, total healthcare utilization cost was higher among those who were enrolled compared to those who were not enrolled. But when we look at follow-up at 12 months, total cost was less for those who are enrolled versus those who are not enrolled by, I believe, several $100s. And the incremental cost was higher for those who are enrolled when we start to incorporate the actual cost for delivering the intervention, as we would somewhat expect. And that's when we look across the whole board, so everyone included. So we do see a little bit more extra costs for those who were enrolled. I think about $82 per additional kilograms of weight loss. But again, when we look at that very specific high risk group, that's when we start to see the cost savings and the cost effectiveness, and that actually those who were enrolled cost less than those who did not enroll. But hopefully those findings will be published very soon.
Thank you, Stephanie. Jessica, I think that you want to go.
Yeah, sure. So there is a very good question for Nisa. Could you comment on community health worker support? And ADA has a very specific interest in supporting community health workers. So I want to give the opportunity to talk about that. Nisa?
Well, thanks for, I'm glad that came up. I think the person who asked the chat question may not be on now, but I happen to have had quite a discussion with our community health worker just a couple of days ago. What I think I'll do is we have a protocol for how we address and incorporate the community health workers. Do you mind if I show my screen? So this is still in draft form, but if you look, we basically are implementing a lot of new things, but at the time that we get a referral and we do our DPP screening, we don't ask a lot of questions about social determinants of health initially. But then if anything arises, they get referred to our community health worker. If nothing arises, obviously during the screening process, after they've kind of done we call it session 0, but actually our meet and greet, we send everyone an electronic survey. So far we've had a 100% response rate, which is shocking to me. But basically, then we have a plan. There are certain questions, if you answer a certain way, you get right to the CHW and they'll get in touch with you immediately. Other questions, the CHW actually goes to our first session, and then they go to a session 2B that's not one of our CDC sessions, where we talk a little more about how the community health worker can support people during the program. And then our community health workers go to periodic sessions. And so basically, once the participants have gotten to know the community health worker assigned to their group, they'll get direct outreach if they answered particular questions in a certain way. And then otherwise, our coaches can refer anytime to our community health worker, or a participant can get to know them and refer themselves, self-refer anytime. And then we do document that. So I'll stop sharing. But we've always had some process in place that's like that, but we're formalizing it more as we get bigger. So we're kind of changing every day with that. But we see that as a really important part of our retention for our program.
Nisa, I just want to say bravo.
I gotta thank my team. I hope Kat's still on, but we've had an
bravo.
awesome CHW team that has been so committed. And I have to say that they do a lot of outreach that no one knows about, but I think it's really valuable.
You're the community experts, so I would be very happy to share back with the National Association of Community Health Workers this. And if you can share that slide with me so I can share it with my counterpart in CDC, that would be awesome.
Okay, yeah, sure. I'll be in touch with you. Thank you.
Yeah, I think that there's other questions. I know that we don't have too much time left, but I see, for example, two big sort of buckets of questions that are remaining. One is about how to sustain the program, how to cover for all the expenses in the program and sustain that effort for a long time. And the other one is how to incentivize the people that deliver the program. And do you pay them? Do you provide some support? And I will open that to probably anybody in the panel here. One is about the program itself. The other one is about the people that implement the program. How do you compensate them? How do you support their participation? Any comments from anyone?
From CDC, we have done tremendous amount of work in looking into retention strategies. From having Google Cards to now having the CDC version of Section 0 that we are about to launch. There are many efforts that has been done into that aspect. And I have to say that we just did a webinar on presenting this CDC's version of Section 0. And one of the things that we have been learning is the fact that Section 0 seems to be a promising practices for enrolling people, getting people into the program, and then to making them compromise to themselves and stay in the program. We have been noticing like around month, 6 weeks or so is when we can really, they start seeing successes in terms of, losing weight and stuff like that. So that tends to motivate them to continue to where, completing the program. The personal success story is another resource, and I just put the link on the website on the chat box. It seems to be another web-based interactive module type resource that many program has been reporting to be very useful in terms of keeping people in the program as well as welcoming new people to the program.
Okay, and following up on that, there was another question about people that don't have insurance and want to participate in a diabetes prevention program. What advice can you provide, Betsy or Nisa, Stephanie?
I can comment on that, and if you want, I can also comment on the sustainability part of things because we've been thinking about that a lot. I think, and Betsy probably can say more than I can about the non-insured, but I'd say answering the sustainability part for us, in reimbursement is going to be key. The Medicare reimbursement is not sufficient, but we will take it. Based on that, other insurers are coming online. One of our big employee insurers at Hopkins has recently decided to cover the DPP, which is huge for us. So I think reimbursement. I think the other thing is our group has realized that we will be applying for grants and trying to look for soft funding, getting institutional support in perpetuity until everyone realizes that primary prevention is something we should be focusing on. Until then, we think that you just have to go out and do that work. And we get lucky sometimes and get those grants, but I think that's where we are with that. I think foundations, community benefits dollars, depending on where you are, those are things you can tap into. That's how we've covered our non-insured people, is we've had grants. We have this huge initiative now. I know that a lot of places, if you go search the CDC site, a lot of the DPPs on there are funded by health departments or they're funded by community benefits dollars from those institutions. So they may be free of charge. As a matter of fact, most programs have not enrolled to be Medicare providers yet. So most of them are probably not billing insurance, as far as I can tell. And Stephanie and Ms. Rodriguez may know more about that than I do.
Well, I just can add to what you just said, that becoming better and better in the reimbursement arena, it's one of the things that many programs will need to learn. And I have shared some resources in the chat box that I think it will help. There is a toolkit there that is very comprehensive. There is the CMS webpage, and there are some other resources that I just put on the chat box that it would be good for you all to do your homework and look into those type of things. So the second thing is looking to, as Nisa said, there are community-based programs that are offered in the program and they don't charge to people. There are not a lot, but there are a few of them out there. And lastly, and don't quote me on this, but it is my understanding, let me put it in those words. It is my understanding that YMCA, for example, it's based on income. So when participants are, this is not something that they go over the places, you know, looking for the spotlight, but there is an opportunity. Let me say it in that word, in that way. There is an opportunity for those that are at the community levels to look to YMCA's, because the membership is income-based eligibility, and you know, people might be eligible for getting into programs without any out-of-the-pocket expenses, or less, you know, you know what I mean.
Yeah, no, that's important. Well, I know that we're running out of time, and before I turn it back to Elisabetta and Jessica to close the program, I'll just say one thing, that I was reviewing some of the data from the National Health Interview Survey, which collects information in the country. And I was shocked by just reading that of those individuals in the country that participated who have been diagnosed with prediabetes, only 50 to 70% of them receive some recommendations from their healthcare providers to improve their lifestyle. And only 3% of them are referred to a formal diabetes prevention program. So I think that there's a huge opportunity and need here to really do a much better job in identifying programs in our communities. Obviously, we need more programs for sure, but those that are available, I think that should be identified, that should encourage for collaboration, developing more programs, identifying means to implement and sustain these programs. But I think that we still have a lot of work to do in diabetes prevention. So I think that's one of the key messages, I think, that to incentivize everybody to think about how to implement these programs in their own communities and identify those that are already there and refer patients. So with that, I'll just stop here and turn it back to Elisabetta and Jessica.
There is something that I want to mention that piggyback to what you just said, Dr. Caballero, and it's the fact that CDC has been looking for some other providers. For example, we have guidance around engaging pharmacists in this environment. There is also, as we speak, we're doing focus group with nurse practitioners, especially those that doesn't know anything about the national DPP, just to learn from them what is the interest and what is the needs to look to every participant as a person potential to be enrolled in the national DPP. So we will be learning from this experience that we're doing as we speak right now. And so stay tuned, because we will be able to do a webinar when we're going to be sharing the lesson learned from that experience that we're doing with nurse practitioners. But with pharmacy, there's a lot has been done. And if you go to our website, there are guidance in there on how to engage pharmacists in this environment.
So back to you, Elisabetta and Jessica.
Well, thank you very much for this session. It was a great discussion. Thanks so much to the speakers and the audience and the great participation. I think we wanted to give just a couple of reminders before closing the session. So one is please feel free to join the ADA Community Health Workers and subscribe for a membership for this effort. If you have interest in doing so, please refer to the professional ADA website to follow the process for joining. And then other reminder, please sign up for the 2022 scientific sessions, ADA scientific sessions, in case you have not done it. So we'll be very happy to see all of you there if you have the possibility. This year, as you know, the meet is going to be in person, but it will have a virtual option as well. And with this, I want now to formally close this session. Thanks again for the great discussion. And I hope everyone will have a great rest of your afternoon and a great weekend. So thank you very much.
Thank you so much.
Yes. Thank you all. That was great.
Good job, everyone.